So, you're prepping for your ICU trauma exam? You've come to the right place. We are going to absolutely crush a high-yield review of the essential frameworks that will not only help you ace that test, but will also, actually save lives.
Okay, let's kick things off with a scenario you are guaranteed to see both on your exam and in the unit. Your patient is crashing, the alarms are going off, and the pressure is on. What is that one single foundational process you anchor yourself to every single time?
And the answer? It's all about the primary survey. It might just seem like a simple mnemonic, but let me tell you, mastering the ABCDEs is completely non-negotiable. This is your mental roadmap when it feels like everything is falling apart.
Okay, so let's get into it. The primary survey. Think of this as your systematic game plan to find and fix life-threatening injuries like right now. It's a process you're going to run through again and again to make sure you haven't missed a thing. So, here it is, right? Airway, breathing, circulation, disability, and exposure. And the key is you do it in this exact order every time. You don't get to move on from A until that airway is secure. You can't skip to C until breathing is managed. Let's break each one down. First up, A is for airway. This is your absolute #1 priority. I mean, a person who can't move air is just minutes away from being dead. And this is huge. You have to do this while protecting the cervical spine. You have to assume every trauma patient has a C-spine injury until it is proven otherwise. All right, for your exam, you've got to know these interventions backwards and forwards. You look, you listen, you feel for that breath. If the airway's blocked, you're doing a jaw thrust. Remember, not a head tilt chin lift to protect that C-spine. You're suctioning out whatever's in there, and you are always thinking one step ahead, ready to escalate to an advanced airway. So, we've got a clear airway, but that's useless if the patient isn't actually breathing, right? So now we move to B for breathing. Are the lungs actually doing their job? Is gas exchange happening? Okay, here's a golden rule for your test. Write this one down. Every single trauma patient gets high-flow oxygen. No debate, no exceptions. From there, you're looking for those killer chest injuries that need you to act now, like a tension pneumothorax that needs a needle right in the chest. Next up, C for circulation. And in the world of trauma, C almost always means one thing: hemorrhage. Where are they bleeding from, and how do we stop it, like, now? The name of the game here is speed. We're talking direct pressure on wounds, getting 2 massive IVs or an IO going for fluids and blood, and don't forget about those big, hidden bleeds. You gotta be ready to slap on a pelvic binder if you suspect a pelvic fracture.
All right, moving on to D for disability. This is our quick and dirty neuro check. We need a baseline stat so we can tell if the patient's neurologic status starts to decline. That could be our only clue for a serious head injury.
Now, in that initial chaos, the AVPU scale is your best friend. Is the patient alert, responding to your voice, responding only to pain, or are they completely unresponsive? It's simple, it's fast, and it gives you a quick snapshot before you move on to the more detailed Glasgow Coma Scale. And finally, we hit E for exposure. You gotta see everything to treat everything, so the clothes have to come off. But, and this is a huge but, this is where a new, sneaky danger starts. And this is so critical. The second those clothes are off, that patient is losing heat like crazy. So you have to immediately start aggressive warming. We're talking warm blankets, warmed IV fluids, crank up the heat in the room. This isn't about comfort, it's about preventing a deadly downward spiral. All right, so the primary survey's done. Now we shift gears into the critical care phase. This is where the fight moves to preventing that second wave of death, the one caused by the body just completely collapsing on itself. Okay, this is a big one for your ICU exam, so listen up. Damage control resuscitation. This is a total game changer, and it kind of goes against everything we used to be taught. The whole point is to stop the bleeding while giving back exactly what the patient lost: blood products. So the big takeaway here is that we've totally flipped the script. We are intentionally keeping the blood pressure a little low. That's permissive hypotension, so we don't blow off the fragile clots the body's trying to form. And we're not just dumping in tons of sealing anymore. We're giving blood, plasma, and platelets in a balanced ratio.
And all of this is designed to fight one of the most lethal concepts in trauma. For years, we called it the lethal triad, but now we know it as the trauma diamond of death.
So for the longest time, we talked about this lethal triad: hypothermia, acidosis, and coagulopathy, where the blood won't clot. But what's really changed the game is adding the fourth point, hypocalcemia. And here's why that's so important. When we give massive blood transfusions, the preservative in the blood bags actually sucks up the patient's usable calcium. Low calcium tanks your heart function and makes the coagulopathy way worse. So now we have to aggressively give calcium during the resuscitation, attacking all 4 points of this diamond at once.
Okay, once you understand that deadly diamond, it really changes how you look at specific injuries. So let's do a quick rapid-fire review of some super high-yield scenarios for your test. This is all about pattern recognition.
This is a classic test question for sure. Tension pneumo versus an open pneumo. For tension, the money sign is that tracheal deviation away from the bad side, and the immediate fix is needle decompression. For an open pneumothorax, that sucking chest wound, your first move is a 3-sided occlusive dressing.
Okay, and here's a fantastic mnemonic for Lefort facial fractures. You're gonna love this. A Lefort I is a mustache fracture across the maxilla. A Lefort II is a pyramid fracture. And a Lefort III is the big one, the mask, a full craniofacial separation. It's a really easy way to remember those injury patterns.
When we're talking about the abdomen, it's all about recognizing the clues. If your patient has left shoulder pain, you better be thinking spleen injury. See bruising around the belly button or on the flanks? That's screaming retroperitoneal bleed. And please, never, ever underestimate a pelvic fracture. They carry the highest mortality of any broken bone simply because you can bleed to death into your pelvis. So we'll leave you with this final thought. You can memorize all the frameworks, right? You can know the diamond of death inside and out, but the real test is when you're in that chaotic mass casualty drill and everything is going sideways. How do you stay anchored to your ABCs when you're completely overwhelmed? That is the ultimate challenge, and really, it's the core of what it means to be an expert in trauma care.